please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about the frequency-specific microcurrent.
I feel like this week has been, I felt like when I was in college, we would have study group and I'd get so excited for Saturday morning study group because I'd have all these questions. That's how I feel Tuesday nights sometimes. I'm like, okay, thank goodness the podcast is tomorrow because I need to talk to somebody about this.
Oh, you have no idea. I'm in the same situation. Can you imagine having a text message fight, disagreement? No, that's wrong. Conversation with Ben Catholi on Monday?
No.
It was really weird because, yeah, Ben, no, it doesn't cross there.
Interesting.
It's got to be central.
Okay.
And so this one, is everybody sitting down? I'm really.
Sitting down. But you know what? I want to start today with a bit of a quote before you unpack it. Because we haven't done it. We used to do a closing quote all the time, and I don't know what happened. We stopped doing it. But yesterday, something fell out of my mouth when I was explaining something. And I'm like, oh, this is really good. I have to write it down. And actually, now that I'm rewriting it, I actually want to put it in my clinic. To make the difference, you have to go somewhere different.
Oh, yeah. The road less traveled.
Or the frequency less utilized.
Yes. Or turn your brain inside out and see how you like that one.
Right. And I think we talk about that all the time, is doing something different. But like sometimes you really, when you look at, especially a patient you've worked with for a long time and you hit that plateau, it's okay. We have to do something different because this is not working anymore. And that's okay that it's not working anymore.
You have to start over.
You have to start over.
You didn't just work on this for 6 weeks. It's okay, let's start over and rethink this. Tell me again.
Yeah.
It's that.
Yes.
Yep.
It's sometimes hearing the same story, but you just pick out something different. It's like going to the core 6 times. I heard it different every time.
Yeah. And it's actually not that different.
No.
I think I've changed 2 little teeny things in the core in the last 3 times.
But it's like you say, you're just ready for something else to digest. You're ready for that extra little piece of information.
Yeah. You have a matrix to put it in. It's like you have a matrix of information and experience.
Yeah.
It gives you a background. And in the beginning, your matrix, I think of it like a honeycomb.
Okay.
You've got little pieces of the honeycomb filled in.
Yep.
And some of the pieces of the honeycomb are half full. And then when you hear something new, or you hear the same thing, like the 8th time come to the core, there's a piece that actually goes in that honeycomb that
Right.
you didn't hear before.
Yeah.
Because you didn't have enough of the little boxes filled in the honeycomb.
Right. I like the honeycomb.
The honeycomb.
Let's talk about
Say the quote again. Say the quote again.
To make the difference, you have to be willing to go somewhere different.
Yeah, and even using FSM is going someplace different.
Yes.
We do different things differently, or the same things differently than anybody else does them.
Right.
And where else do you start out saying, that's just nerve pain? That's okay, I can do that.
Right.
Yeah, it's
Okay. So you need to go to your story now.
I don't need to, because I'm not, I wish I had that page open to Netter. There's everybody that has Netter on your desk, go to the page in Netter that has the bottom part of the underside of the brain that shows the cranial nerves that come off the medulla, and then the cranial nerves that come off the pons. All right. So I had a patient this week that Monday said and he is 50 something, super healthy, already retired. It's just healthy lifestyle, organic food. David Musnick would love him, right? And would approve. And high beef. And he said, I had an event, and it was about 6 months ago, where the left side of my head, my left eye was like, there was just something exploding and painful behind my left eye. I couldn't open it. I had trouble swallowing. Just the whole side of his face he couldn't move it. It hurt like crazy, like the top of his head and the whole side of his face just exploded with pain. And it lasted 12 hours, 24 hours in there.
Keep talking. My camera's gonna go away because it's blinking that I have to plug something in, but I'm still here. I'm just you're not gonna see me for a second.
Go plug something in. Oh, wait.
Okay.
Okay. And so the next day, so virtually immediately, the right side of his body, his head, face, neck, arm, trunk, and leg, the whole thing was circled. And so when he came in, I said, oh, goody, a thalamic stroke. Those are easy. I really shouldn't have.
I'm back just to make that face.
I know. I shouldn't have said it that way, because the right side of his body didn't have pain like a thalamic stroke.
Okay.
It felt hot, but physically the temperature was the same. Like when he put a temperature gun on the left and the right, the temperature was the same.
But he felt it.
The whole right side of his body felt hot. And when he got in the shower, he had to shower the left side, and the right side, when the warm water hit his right side, it felt like electric shocks. Every time a drop of water hit, it felt like electric shocks. So it felt pain when he should have felt warmth.
Right.
Okay, if that doesn't make your brain hurt, I'm not finished yet. And he had to learn to cook with his left hand, because if he cooked with his right hand or took something out of the oven or the microwave with his right hand, he couldn't tell if it was hot or not. It always felt warmer than the left side, but he could not perceive temperature. And when something warm hit the right side, it felt painful. And it's so I'm texting Ben, what the hell?
Yeah.
And Ben starts talking about spinal thalamic tracts, and it's the pyramidal tracts, and it's in the medulla. No, Ben, it's the left side of his face and head and the whole right side of his body. That puts it above the medulla. For those of you that are not neuro geeks, all of the pathways that come up the spinal cord cross either in the spine or in the brainstem, in the medulla. They all cross. Anything that happens on the left side of the head that results in full body right-sided pain has to be from the thalamus. It has to be in the thalamus. It has to be in the midbrain. Right. So Monday, I did the thing we do for thalamic strokes. It's not a normal thalamic stroke. I've never seen a thalamic stroke like this, but We'll try 40 and 89 from neck to feet.
Yeah.
Zero change. And that bothers me. So I came home and thought about it, and I looked, if you Google, how do you perceive temperature? It takes you from the spinal cord up, and it crosses someplace. It gets to the thalamus, and then it goes to the sensory motor cortex on the right side. So it comes up the spinal cord, goes to the right side. Okay. Then you look at what nerves were involved. Every nerve, every cranial nerve that came out of the pons on the left side got hit by this event. It was either a hemorrhagic stroke or an ischemic stroke. Either one could have done it. Probably ischemic, but no way to tell. Then I asked him, what time did it happen? And he said, oh, 5, 6 o'clock in the morning. And I said, do you snore? Yes. You go home and get a sleep study. You have sleep apnea. You had a stroke. He said, yeah, but they did an MRI and they can't find it. And so the problem with a regular MRI is that the slices are 3 millimeters. And you need a 3T or a thin slice, 1 millimeter, because whatever this is tiny. It only affects temperature. He has no other deficits. Cognitive function, verbal function, because the parietal lobe has a piece to play in the perception of temperature, but it does so many other things that it could not have been a parietal stroke. He had no trouble with word finding or language or movement or balance, or there was no thing except this weird, when something warm hits my skin, it feels like an electric shock.
Right.
When anything touches my arm or trunk or leg, it feels like an electric shock. Reflexes were all normal, so it's not in the spinal cord. So I looked at this diagram on the internet, and it's like, how do you perceive temperature? And the message comes up the spinal cord, gets to the thalamus, and goes from the thalamus to the sensory cortex. Thalamus to the sensory cortex. What would happen if the thalamus stopped, like a teeny piece of the thalamus? Because if you look at all these cranial nerves, they're right next, they're that far from the thalamus. And we had to find the layers of the brain, and he and I are doing this together with Netter open. And then we found the circulatory system, and it's okay, if that artery went wacky, it would damage that. And then the ischemic injury would damage the thalamus, which is that far away. And I explained to him, you understand I'm making this up, that I have no idea what I'm talking about, but it's a model.
Yeah.
So what if the thalamus took temperature information from the body and stopped, my brother says, hi, okay, and stopped sending it to the sensory cortex? What if temperature information landed in that one spot in the thalamus that was supposed to send temperature up to the sensory cortex? And the thing can't be any more than a millimeter.
Okay.
And it's got to be a little teeny dot the size of a pin that's injured. And the 3 millimeter slices of the MRI in his brain just missed it. And the only thing I could think of to do, and you can understand why I was nervous about this was to treat the midbrain for trauma, torn and broken, necrosis, because that little piece of the thalamus was dead.
Yeah.
And then increase secretions in the thalamus to get it reconnected to the sensory cortex, just the sensory strip.
Yeah.
And then informed consent is telling the patient, okay, the first time I ran this frequency combination, I made a guy in a coma cry. So running this frequency makes me a little nervous, but it's the only way I can think of to get your thalamus to connect. So as I'm running it, if anything weird happens or you feel anything odd, let me know. So we hooked him up neck to feet, and I ran 81 and 89, and he didn't start crying, and he didn't have any pain.
Wow.
And after about 20 minutes, I took a hot towel out of the warmer and I laid it on his left leg. Yes, it's warm. Laid it on his right lower leg. It's not zapping me. It's warm. Okay. So we ran it another 20 minutes and then went up to his knee. That's warm. Thigh. That's warm. Abdomen, that's zappy. Okay, we're not there yet. Treated him an hour and a half on 81 and 89. Got up to his shoulder and his upper arm. His hand was the last to go. And when you look at the homunculus and the thalamus, it makes sense.
Makes sense. Yeah.
And then it wasn't quite normal. And I thought, what if the sensory and motor cortex has now not heard from this part of the thalamus for 6 months? What if the sensory and motor cortex dropped the ball? So then I switched to 81 and 92. And for those that are listening, it's increased secretions in the sensory cortex, sensory motor cortex. And I bop back and forth between increasing secretions in the thalamus, necrosis in the thalamus, come on, vitality in the thalamus, increased secretions in the sensory motor. And we got down to where his hand could feel warmth, but it was just a little prickly.
Wow.
And we did it. It took an hour and a half, but it was the thought process that was painful. The first part was texting Ben Catholi and say, yeah, that can't be it. It can't be in the medulla. It's got to be higher than that because it doesn't cross sides. Pain was on the left, damage is on the right. It's the whole right side, which includes the head, which means it has to be the thalamus.
Right.
And it worked. So do something different to get me to run 81 and 89 on somebody. Okay.
You had a very sound hypothesis for using it. You didn't just come up with it. It wasn't AI derived. It wasn't somebody said. It wasn't some canned protocol. This was, like I said, a very sound hypothesis that walked you through pathology and anatomical structure to get you where you needed to go. So well done to you for being brave enough to try something different that had a terrifying outcome the first time you used it, but in a completely different setting. And so this is the thing of when we have scary things that happen to us or adverse outcomes, we have to think, okay, is this the same setting? Absolutely not.
And you have to, I think what I'd encourage the people that are listening, what I'd encourage them to do is be willing to think through from the beginning to the end.
Yeah.
What was the first symptom? It was all up here and it affected every cranial nerve in his face.
Right.
We opened up Netter, thank God, to that page that has the bottom side of the brain and all the cranial nerves. and then flipping through Netter in those 5 pages to find, could an ischemic event or bleeding event, probably ischemic because he snored, have an effect? Is it in the right place that it could affect the thalamus?
Yeah.
What would happen, and why didn't it show up on MRI? Because MRI, that's one of those pieces of the honeycomb.
Yeah.
25 years ago, finding out that MRI slices are 3 millimeters.
Right.
And that's stuffed in a honeycomb. And T3 or thin slice MRIs are 1 millimeters. And that's another little factoid that's in a different things you happen to know about MRIs, and if he had a stroke, why didn't it show up on the MRI? If you look at the thalamic strokes create pain.
Right.
The injury was too small to create pain. It had to affect a portion of the thalamus that receives temperature information. And I wouldn't have known that if I hadn't Googled how do we perceive temperature. There's this little red line that goes up the spinal cord, and then it does that and does that, and then it goes to the thalamus. There's this little red line, and there's a dot in the middle of the thalamus, and then another little black line that goes up to the sensory cortex on the right side. And it's
right. And the neuro geek in you was secretly like pretty excited to do this extra research and to fill your honeycomb with a little more neuro geekism. Let's face it. I get the same way with any of the orthopedic factoids. I probably learned once upon a time, but I learned it and then it fell out of my brain because I had to make room for other things. And
you didn't need it. You don't remember it until you need it.
Exactly. I want to talk about imaging for a second because we go back and forth with our orthopedic testing and ruling out pathology and the need for imaging. And Dr. Musnick had talked about his adversity to contrast MRIs and even X-rays and MRIs in general. Are we doing this? Are we exposing our bodies to harmful toxins if we don't need to? And I always look at imaging as something favorable, especially if we've tried everything conservatively and we don't know what's going on. And I was talking a little bit about this in my infamous hip talk that we did at the Advanced. But the talk was obviously about hips, and we're talking about stress fractures or in the hip and stress fractures that can happen in the SI and the pelvis that are not as common, but they do happen with runners. And I had a doctor that I wasn't sure if it was a stress fracture. They said there was no need to go down imaging. It was completely soft tissue. I treated it, and you have that feeling of something just isn't right here. It was very stress fractures, the musculature surrounding a stress fracture, especially in the hip, are the only word I can think of is like dramatic. There is splinting and guarding that is excessive. There is exquisite pain in the musculature. And orthopedic testing can look normal. Finally, she went for an X-ray and she's like, good news, I don't have a stress fracture. And I'm like, stress fractures don't show up in X-rays though. You need an MRI for this. And that's not true. So I had the argument with the client. Yeah, my doctor said I don't have a stress fracture because it's not in the X-ray. So what we typically see is this discontinuation sometimes of care. The X-ray, if the X-ray was abnormal, we go for an MRI. But again, this patient was not responding to anything. Finally got the MRI, and lo and behold, there was the stress fracture. And so we see this as edema. And you and I were texting about bone marrow edema and the options for frequencies for that. I use 14 and 238 for bone marrow edema. And this was another Ben Catholi text message that I had tried. Yeah. There's some other options as well. But I really found that, and even with shoulder dislocations, when there is exquisite pain after a shoulder dislocation, it's impossible for a shoulder to dislocate without trauma to the surrounding soft tissue and also to the bone itself. So a lot of times,
and the labrum, it's like it can't be done. You can't go and not hit the labrum and the anterior part of the
No. So a shoulder dislocation always has torn and broken in the labrum and torn and broken in the connective tissue and torn and broken in all the things. However, and I noticed this, even my daughter was patient 0 for me with this one, was none of the, and she's my FSM baby. Like, she has been raised on FSM. It wasn't taking the pain away. Nothing I was running for torn and broken and anything touched the pain until I rewatched my friend who is an orthopedic surgeon go through her MRI and kept talking about the bone marrow edema. I'm like, I haven't treated her for that yet. Ran bone marrow edema, and she's, Mom, finally you got it. It doesn't hurt anymore.
Oh, thank God. Yes.
So again, and it's not to say that torn and broken wasn't necessary. And it goes back to what we talk about all the time. Like, where do you start? Get the person out of pain. Yes, you have to run torn and broken in the labrum. And it healed the labrum. She didn't need any surgical intervention after that. And even the surgeon said, I don't know what you're doing, but the labrum looks fantastic. I'm like, great. However, the pain was there. And so the bone marrow edema frequency was the only thing that helped her with the pain. Not the nerve, not concussion, not anything else but that.
It makes perfect sense. And it depends on the setting. It's entirely possible to treat all the things that you think should work.
Yeah.
And if they don't work, think again.
Go somewhere different.
Think something different. And it's, how about the bone? So you could think those things without the imaging.
Yeah.
And this is for the people that are listening, and some of you have a lot of mileage. When you think again, when you have a lot of mileage, you know that after you run the stuff that should work, at the end of 30 minutes, it should be better. And not only is it not better, it hasn't changed. So that's not it. So the place, it takes a while to get there. For the people listening that are new, it took me 5 years and 30,000 patient visits to believe and understand with my brain and my fingers that the frequencies always do what they're described as doing, but they only do what they're described as doing. So at the end of 30 minutes, if nothing has changed, you're not doing the right thing.
Yeah.
So you rethink it and you put the anatomy in your head, or you open up Netter. What is it?
Yeah.
What didn't I do? And you look at the list of what you did and what you didn't do. Bone. So the patient I had last week, there's now a protocol in my personal mode bank called facet repair, where we run necrosis and torn and broken in the cartilage, the periosteum, and inflammation in the bone. And that's not in any of the subacute or chronic facets. It's different. There's cartilage is always getting smacked. So it doesn't have good blood supply. So it's gonna die.
Right.
In quotes.
And when we boil it down, whether it's a facet that is arthritic and dehydrated and, like you said, air quotes here, dying, we always want to create movement, right? Everybody is an athlete. A squat is a squat. This is my whole like essence of being, is to get people and their little tiny baby joints to move better. And so when you think about that as a facet, it's no different than an ankle that is stuck and is immobilized. We want to get pain-free movement to the area. Why? To get blood to come in and out of the area, to feed it, to nourish it, to go into circulation, et cetera, et cetera. So like the cascade of the effect that even segmentally in an L4, L5 facet joint has a ripple effect for the whole spine.
Right.
And it's just the way that you talked about what is happening. It's what we do with FSM is very simplistic, and it is very complicated the dichotomy between the two, science and art, is just, it's beautiful. I love it. It drives me to the point of insanity. But
Yes,
when you break it down like that, though, of course, let's try some different strategies and go outside the mode bank and think about what's happening and why is the muscle responding? And we always say it's never the muscle because it's responding to something, like that woman's hip. The muscles, the glute med, the TFL, the glute min were in this catastrophic holding pattern because there was bone marrow edema. Like there is no way putting a needle or an elbow in this person's glute med was going to help her pain.
nope, nope. And Lisa says, if you always do what you always did, then you'll always get what you always got.
Yeah, I've heard that quote. That's fantastic, but that's exactly it. So when I go to somebody for manual therapy and it's always the same thing, and I say it's not getting any better, but they do the same thing. So it's for the patients that are listening, like that should be a red flag to at least have, I'm not saying abandon your practitioner, but at least have the conversation. And it's within your right to say, we've been doing the same thing and the outcome has been the same and I'm not getting any better. Can we try something different?
How do we think about this differently? The thing with FSM is that it doesn't suit everybody's mind, but the thing about it is that it's how you think about the injury, the pain generators, the pain generators,
Yeah.
the pathologies. How do you think about it? And
Right.
FSM is a combination of art, intuition, and science.
Yes.
It's like you have to have the background.
Yeah.
And so we spend a fair amount of painful time during the core doing, this is what a facet looks like. These are the muscles that attach. These are the muscles that have to move it. So this patient wanted to get rid of the bone spurs in his neck. He's only 25.
Right.
He's got bone spurs in his neck and he's all freaked out about them. It's like, bone spurs are easy. Excuse me. It's like bone spurs are there because the muscles are so spastic, they're not moving, but they're not moving and they're spastic because the joint's inflamed.
Yeah.
The muscle has been instructed to keep the joint still. So these little teeny muscles that are an inch long, and I opened the book. Oh, I did remember the part where I said I didn't change the core slides.
You changed, of
I
course.
changed the core slides to put the pictures of these muscles in. They're this long. How do you, and then I taught him how to contract them. And it's what happens when I contract them is they move. And as soon as they start moving and you run the frequency to reduce inflammation in the joint, then they won't have to be so tight. And then you exercise them. And in about 3 months, if they're moving, you do your exercises twice a day like you're supposed to. In 6 months, we redo an x-ray and at least half the bone spurs, if not all of them, should be gone.
Right.
And it's, oh, so there's the science, Wolff's Law, the anatomy, the pathologies involved in joint motion. There's the intuition and the art of combining the anatomy, mechanics, biomechanics, physiology with the effect of the frequencies and putting it all together to create an image of what needs to be done to create long-term repair.
Yeah. I think having multiple strategies in place and having multiple hypotheses has also been something that I have learned. You said it before, flexibility of mind, not getting attached to the outcome. I love collaboration. There's many patients that I have referred and sent, and we have a team approach. Things like frozen shoulder that can be extremely frustrating. I have a very healthy, happy woman that comes in and has been coming in very regularly for the past year with varying degrees of frozen shoulder, had it on one side, fixed it. Now the other side's showing signs of it. It comes, it goes. I have exhausted everything that I can do. I sent her to a great colleague in town who's a chiropractor. She's fantastic. I said, I think this is coming from her neck. I don't think this is frozen shoulder. She's a great cervical spine adjuster therapist. Things were working and then they stopped. And so patient was very frustrated. I said, listen, you've been doing everything that you can conservatively at this. I think it's time we bring in somebody else into the team. My friend who's the orthopedic surgeon. Let's get some imaging. Let's get some fresh eyes on it. And she's like, wow, and she loves that I have somebody that I can refer her to. And I think, and I can learn from the situation, and long story endless, 5 days of prednisone and her shoulder is not frozen anymore.
Place for it.
There's a place, and that, again, this also tells us something. She's been having some other little health issues here and there. And I'm like, okay, so if an anti-inflammatory makes all this difference with not just your shoulder, but all these other things, let's talk about inflammation and diet and stress and all the things that we know are players in something like frozen shoulder, treating the vagus and sleep. And
you send them with a note to their GP saying, please do the hemoglobin A1C and the HSCRP, and let's talk about your sleep.
yes,
And let's talk about your diet and digestion and how do you feel after you eat.
right.
And your shoulder was doing fine until when?
And having those conversations, again, that having a collaborative approach with other practitioners can really help explore those. So she was talking about perimenopause and she's talking about getting a dietitian. That's great having a dietitian that's going to give you a meal plan. But if you don't know if you have food sensitivities, the best meal plan in the world is not going to help you if you're putting stuff down your throat that you are reacting to.
Well, then if you're perimenopausal, you're automatically estrogen dominant, which leads to inflammation.
Exactly.
So then you find somebody that will test your hormones. So you have to have a functional medicine trained OBGYN in your back pocket and get somebody that'll test your hormones and get her on progesterone and get the estrogen balance down and see what that does. Because it might not be one thing.
Right, exactly. And when she said, this is great at being on this prednisone and I feel fantastic, that's not the solution though.
No, you can't stay on prednisone forever.
No, but this tells us a little bit more of the story, right? Just doing manual therapy. It would be great in a perfect world if every frozen shoulder could be treated with a scapulothoracic manipulation, but it's not. Like it's just not that easy, but it's asking those questions. And if you were just manual therapy trained, I guarantee you, like the conversation I have with frozen shoulder, I always go, wow, nobody's asked me so many questions about my shoulder. How is this related to my shoulder? How is this have anything to do with that? And I said, and then you can explain it. And I think the more you explain it, the more information patients and clients start giving you. Oh, nobody asked me about that. But you know what? This is what happens after blah, blah, blah. And so again, you're not expected to have all the answers, but I feel like it's my due diligence to gather as much information as possible so that when I do call somebody else into my little team, I can give them a pretty comprehensive history and say, this is what we've tried, this is what they've experienced, this is part of their history. It saves everybody time. And again, you get those fresh eyes on the case that are like, oh, let's try this. And then I get to learn something.
And it's the reason why we no longer have a physical medicine and a visceral medicine track, thanks to you, because there's no separation. You can do everything you want with physical medicine, but if they have leaky gut and they're allergic to whatever and they're estrogen dominant, and this one lady in the clinic has 3 autoimmune diseases, 3 at one time. That was my other,
Just trying to keep my coffee down.
I know, it's 3 at one time. She has myasthenia gravis, she has psoriasis, and she has myasthenia gravis, psoriasis, forget what the other one is, but she had 3 of them at the same time. And then she's got, rheumatoid arthritis. She's got swan neck deformities in her fingers and full body pain. And the first day we did as much of a physical exam, her pain level was a 7. And there was no way I was going to treat her on the first day with anything except 40 and 10, concussion in vagus, and 40 and 89. It just, I'll examine you. Oh, I have this abdominal thing. It's like, I'm not going to touch you. My knees hurt. I'm not going to touch your knees. There's no point in doing anything until we get the 40 and 10, the central sensitization down.
Yeah.
I'll work on your knees tomorrow. So while I'm working on her knees and her shoulder, and still haven't done her abdomen, there's just part of her history. There's these 2, 3, she has Ehlers-Danlos, but she had these 2 auto accidents. One where her head went through the windshield. The other one where the steering wheel broke her sternum, and then she hit her head, and nobody ever suggested to her that her shoulder pain might have something to do. She's had zero imaging on her neck. And that's a good face. And her knees are so messed up that there's no way to get a patellar reflex.
Wow.
Because she's got RA,
and
her knees need replacing, but she's 60, 70 pounds overweight. And there's no way she can have her knees replaced until that gets under control.
But how do you not do neck imaging after all that trauma from the MVAs especially?
Because it was 1985 and she was a kid. And it was just sore for a couple of days.
Wow.
Nobody, Then I said, why are you not on an immune suppressant? You have 3 autoimmune diseases. Your vagus nerve has been turned off since X, because that's when your first autoimmune disease showed up. And then the second one. And then she's in her 50s and she already has swan neck deformities in her fingers. And she said, can you fix that? And I said, absolutely not. It's not reasonable. Why are you not on an immune suppressant? She said, somebody suggested it, but I wanted to do things naturally. It's no. Just no, not always. I can treat your vagus and we can get your immune system to quiet down so you can reduce. And she gave herself gastritis and a gastric bleed by taking too much Advil.
Oh, wow.
So her gut's full of scar tissue. And then something about the wrong drug. It's like she doctor hops. And then it's like she keeps picking the wrong thing, making decisions that are bad for her. And there was something about that just made a voice in the back of my head. And I said, by the way, what was your childhood like? What about your mom and dad? What was home like? Oh, mom was bipolar and alcoholic. My dad was nice, but he wasn't around much. And he was an alcoholic too. And then we had the conversation. And she can't do this, that, and the other thing because she has to take care of her mom. The mom that was bipolar and abused her and all that. And she's got to take care of her mom. And it's because of the money she's spending on her mom, she can't do this and that for herself. And I said, whoa, stop. We need to have a conversation about being an adult child of an alcoholic and why it is that you keep making choices subconsciously to sabotage yourself. When you're in an airplane, they say, put your mask on first, and then you put the mask on your kid.
Yeah.
You have to take care of yourself first. And you've made all these decisions, not listening to the doctors that told you the right thing to do, and listening to the doctors that made you worse.
Yeah.
That's a kind of self-sabotage intuition that's not an accident.
Right.
You didn't find me by mistake.
Mm-hmm.
Made a good decision coming here, but I'm here to tell you that I can't help you. I can give you a custom care on Friday, but I can't help you until you write on the mirror in the bathroom, I love you, and you read that 10 times a day until your care for yourself becomes the norm, so that subconsciously you start to make choices that are good for you. You learn to sacrifice yourself and take care of your mom. When you were a kid,
Yeah.
you have to unlearn that.
Right.
You're 56, you're young enough.
Yeah.
You can do this. And that was a come to Jesus moment. That was a 2 Kleenex for the patient moment.
Yeah.
And that's a piece of it too.
Yeah, the psycho-emotional, psychosocial behavior component, you have such a leg up on most of us because of your educational background.
On my personal background, I was raised by a workaholic narcissist, and my mom was an alcoholic for most of my teenage years up through maybe my early 40s.
Right.
And so I read about adult children of alcoholics, and it's like there's 10 things on the list that adult children of alcoholics do, and I didn't miss any of them. And so you learn to recognize that in your patients that come in that are a hot mess.
Yeah.
And you do the FSM stuff, and I can do some things with FSM, but it's like pouring water down a rat hole.
It goes back to that stable state. We can do miraculously. We started the show with all these things that you did with your patient and the miraculous change in temperature that you were able to help this person with. Conversely, there's some things that FSM just can't do, and that or you have to just be willing to know what you're up against when they have that type of history.
So there's other pieces that goes in one honeycomb place, and
Right.
use of immune suppressants. You know how I hate immune suppressants. They make me crazy.
Yeah.
But you get somebody with 3 autoimmune diseases, give me a break. You should have been on an immune suppressant 15 years ago, and you might still have hands that work and knees that don't need replacing. I wanted to, I like the honeycomb.
Yeah, that's a great visual. And
visual.
Yes.
And there you go.
Yeah. We have a question before we run out of time. So somebody had written, visited a natural approach dentist as a second opinion for a root canal suggestion from a standard dentist. She will clean out the cavity, do a 3-month filling with clove oil to stimulate healing. They mentioned using an anesthetizing shot, which made me think of FSM. Could this be replaced by FSM, and are there dental applications of FSM for dentistry for things other than pain? There is many. Mary Ellen Chalmers, we can thank her for patenting the use of FSM in dentistry. There's also an amazing dentist in Southern California that is using FSM on a dental appliance right now. But I'll let you take it from here as far as what this person could maybe do.
Yeah. Here's the first thing that makes me nervous. And that is the root canal was suggested by the standard dentist. The question is why? What does the dental x-ray look like? Then the second opinion dentist said she's going to clean out the cavity. Okay. How deep is it? And do a 3-month filling with clove oil to stimulate healing. Okay. I'm not familiar with the effect of clove oil as anything but an anesthetic, so I'm not sure how it stimulates healing. No deep root inflammation. How does she know? Unless they did a 3D cone. Did they do a 3D cone beam? That's the next step for me.
Yeah.
They
See what's
find a 3D cone beam, spend the 300 or 400 bucks and find out what the bone looks like under the tooth. And the challenge with anesthetize using Novocaine or lidocaine, one of the canes, to numb the involved root, is the challenge with trying FSM for that is we can't get at nerve cell body. It's in the middle of your head. So it just isn't going to work. After you get the filling, after you have the tooth pulled, oh no, yeah, okay, don't, sorry, we just got to another hot button here. X-ray is not showing bone decay. The 3D cone beam is much better than X-ray, yes. So I had a root canal, actually had 6 or 7 root canals. And I had a root canal up in this upper left side. And the dental X-rays, the cortical bone in my jaw is so dense and strong that the dental X-rays were completely normal. Mary Ellen would not give up. She said, there's no reason you should have had heart disease. You shouldn't have had an open heart surgery. You shouldn't have had a stent. Something's not right. So the dental X-rays were completely normal. Hi, puppy. And the 3D cone beam showed not only the necrosis around the root that they just did the root canal. I had root canals on all 4 quadrants, and the bone around every root canal was dead, was infected and necrosed. So I have one dentist here in Portland that I send 3D cone beam patients to, or I send them home and tell them to get a 3D cone beam, but it has to be somebody that has the new software that's good at reading it. And no, dental x-rays said that my jaw was fine, that this root, which was sore up at the gum line, was just fine. And the 3D cone beam showed that the cancellous bone around the root is completely dead. I had osteonecrosis in all 4 quadrants of my jaw by 3D cone beam. The oral surgeon that did my root canal, I showed him the 3D cone beam after I had the tooth removed, and he actually got angry. We could have saved that tooth. That tooth gave me a heart attack.
Oh.
He said that imaging shows too much. That's a good face. The imaging shows too much. There's too much detail, and we're not sure how to interpret it. So there we go. And it's, yeah, no, it's no.
Yeah.
No, what people don't understand, and I didn't understand, but Mary Ellen did understand, was that root canals don't fail, ever. May take them 20 years, but
Right.
they never don't fail. And when the bone gets infected, it creates an immune system upregulation that in my case caused both of my hips needed replacing and gave me a heart attack.
Yeah. And I think a lot more dentists, especially my dentist, who I would say is a very standard conservative dentist, it's nice to see them talking more about the mouth-body connection. Like I do think there is a good change happening in dentistry. But one thing I wanted to touch on, if there is a potential infection or there's something happens, it says clean out the cavity with clove oil to stimulate healing. And if she's using FSM for pain and it is using something with the 40s in it, could that not make something worse?
Oh, yeah. Yeah.
Just thinking, I'm just being devil's advocate for in splicing in FSM at this point too, when there's something that's could be potentially festering that you don't know about.
And Catherine says the biological qualities of clove bud oil include being antifungal, insecticidal, antibacterial, antioxidant. It's been used in food for its antimicrobial component as well as flavor. CEO had, I'm not sure what CEO is.
Maybe clove oil.
Is that clove oil?
I don't know.
Clove something oil. Has a large amount of eugenol, which has antimicrobial characteristics. That's cool. Yeah. I just remember, oh, never mind. It was a movie where this bad guy drilled holes in this guy's teeth, and he was, as a torture method, and he kept putting clove oil on to anesthetize his teeth. So I didn't know about the antibiotic properties, but I did know about Dustin Hoffman was, and it was what was the name of the movie? Kevin, oh, come on.
Sounds terrifying though.
Oh, it's gross.
I have enough fear about going to the dentist.
Yeah, but the good guys won in the long run, so it's okay. Marathon Man, thank you, Annie. There we go.
Oh.
There you go. Yep.
I'm not sure what she cut and pasted, not sure what CEO is, but I'm guessing it's clove something oil.
Yeah. I would.
But I'm just
that. And then Kevin put in the link for frequencyspecific.com FSM-dental. And Mary Ellen is about ready to put together an FSM course for dentists. We have a lot of dentists in our team. Oh, clove essential oil,
there.
CEO. Okay.
Thank you.
Thank you.
Makes sense.
We have such a knowledgeable group. It makes it so much easier.
It's like the hive. We have the honeycomb and we have the hive.
Yes, we do. Yes, exactly.
And it's 4 o'clock.
How'd that? I guess it happened the regular way.
Every day.
It happens. Fastest hour of the week.
Do you have a closing quote?
I don't. I felt proud about the opening quote. So maybe we'll close with the opening about be the difference and be proud of doing something different.
And I like Lisa's quote. Be proud of doing something different. But if you always do what you always did, then you'll always get what you always got.
Yes.
And so there you go.
Yes.
That's a good one.
Yeah. Yay. All right, everybody. We'll be here next week.
See you next week.
Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.